Live from Boston, my name is Emilio Madrigal. Today is October 20, 2020. I am joined remotely by my good friend and colleague, Rafat Manan, who's at UPenn in Philadelphia right now. Today, we are happy to welcome Dr. Kyle Strickland, who is an assistant professor of pathology at Duke University Medical Center. He will be delivering the 7th lecture of the GYN OB Pathology Pathcast series. And the title of his talk today is Endometriosis and Associated Neoplasms of the Ovary. As always, please feel free to post questions, comments in the Facebook and YouTube chat windows, and Rafat and I will make sure to pass those questions and comments along to Dr. Strickland. And so with that, I'll just pass the microphone over to Dr. Kyle Strickland.
Hello. I'd first like to start out by thanking Carlos, Fabiola, Emilio, and Rifat for the opportunity to speak today. My name is Kyle Strickland. I'm an assistant professor in the Department of Pathology at Duke University, and today we're going to talk about endometriosis and some of the ovarian neoplasms we see associated with it. I'd like to start out with a short clinical case, and then I'm going to talk about endometriosis, including epidemiology, symptoms, pathogenesis, histologic features, and its relationship to ovarian and peritoneal malignancies. We'll spend some time discussing endometriosis for two reasons. One, it is a common and important gynecologic disease process. And two, there are molecular and pathophysiologic features that help explain why neoplasms arise in endometriosis. Then I'm going to move on and discuss endometrioid, clear cell, and seromucinous tumors of the ovary. However, it's important to keep in mind that since endometriosis can affect all areas of the abdominal cavity, these neoplasms can occur as peritoneal primaries, although this is rare. So we'll start with a clinical vignette. Our patient is a 48-year-old woman presenting with persistent abdominal pain and pelvic pressure. She has a history of prior pelvic surgeries, including removal of a left ovarian endometrioma 6 years prior to presentation. According to the op note at that time, the right ovary appeared normal. CT imaging was performed and demonstrated a 7.2 centimeter right adnexal mass and another 1.7 centimeter high density nodule anterior to the sigmoid colon. The patient is taken to the OR for right salpingo-oophorectomy, resection of the pelvic mass, and possible staging. A frozen section of the pelvic mass is performed. In this photomicrograph, we can see sheets of malignant cells with somewhat generous cytoplasm and pleomorphic nuclei infiltrating fibrous tissue. A diagnosis of high-grade adenocarcinoma is made. The patient undergoes staging for suspected stage 2 disease, including peritoneal biopsies, omentectomy, lymph node dissection, periaortic lymph node sampling, and rectosigmoid resection with reanastomosis. After processing the specimen, final pathology of the pelvic mass demonstrates sheets of malignant cells with clear cytoplasm, pleomorphic nuclei with multinucleation, and prominent nucleoli. Immunohistochemistry is positive for nuclear markers PAX8 and HNF1 beta, and for cytoplasmic markers napsin A and AMACR. Resection of the sigmoid colon demonstrates deeply invasive endometriosis. At left, you can see a 1x image of the full thickness of the colon demonstrating the deeply invasive nature of the patient's disease. Here at the mucosal surface, we can see endometrial glands and stroma directly adjacent to colonic epithelium. In other sections, the endometrial glands take on a crowded appearance with cytology that is distinct from the endometrial glands at the surface. Here you can see two distinct morphologies of the endometrial glands, including crowded glands with eosinophilic cytoplasm and basally placed nuclei, and the more normal appearing glands with pseudostratified nuclei. Ultimately, the patient is diagnosed with a stage 1A clear cell carcinoma of the ovary and deeply infiltrating endometriosis with foci of atypical endometriosis. I like this case because it demonstrates several teaching points. First, at the time of frozen section, the distinction between the histologic subtypes of ovarian carcinomas is not normally necessary. In the frozen section, the clear cytoplasm appears eosinophilic, and it's somewhat unclear whether this is a serous endometrioid or a clear cell carcinoma. The solid and infiltrative growth pattern along with pleomorphic nuclei allows us to tell the surgeons that this is a high-grade carcinoma so that they can proceed with staging. Second, the clinicians originally expected metastatic disease due to the sigmoid colon nodule, which in actuality is a focus of deeply invasive endometriosis. The presence of atypical endometriosis is not that uncommon, especially in the context of a malignancy, and we'll discuss that further in the lecture. Endometriosis is defined as the presence of endometrial glands and stroma outside of the uterine lining and the uterine musculature, and this definition is important. Endometrial glands and stroma inside of the uterine musculature is called adenomyosis. For trainees watching this video and for illustration, the photomicrograph on the left depicts normal endometrial glands and stroma. On the right, this photomicrograph is taken from a focus of endometriosis. Notice the robust similarities, including endometrioid glands with a single layer of epithelium composed of cells with cigar-shaped nuclei with a vertical orientation pointing toward the lumen. Glands are sharply defined from the surrounding pale stroma composed of small cells with spindle-shaped nuclei and inconspicuous cytoplasm. These cells are supported by a delicate reticulin network. Up front, it is important to emphasize that these cells are functional and respond to hormonal stimulation. Degrees of pseudodecidualization may be seen depending upon the cycle and treatments taken by the patient, such as exogenous administration of progestins and even during pregnancy. Regarding the epidemiology of endometriosis, the true prevalence is unknown, and this is mainly because definitive diagnosis usually requires surgical visualization and preferably histologic evidence. However, we do know that it is a common disease, and it is estimated that around 10% of all reproductive age women have endometriosis. The peak prevalence appears in women aged 25 to 35, but it can occur in premenarche, adolescence, and even in biologic males. There are a number of factors that are associated with increased risk of endometriosis, including Asian ethnicity and prolonged estrogen exposure, seen in patients that experience early menarche, short menstrual cycles, or nulliparity. Endometriosis is also associated with low BMI and uterine outlet obstruction. Interestingly, cigarette smoking and greater parity are associated with reduced risk. Surgical evaluation and definitive diagnosis is often delayed because patient symptoms are vague, often overlap with other GYN and GI processes or diseases, and surgical diagnosis entails risk. Pelvic pain, including dysmenorrhea and dyspareunia, infertility, or an ovarian mass are the most common presentations. The site of endometriosis can be associated with atypical symptomatology. For example, endometriosis of the bladder can be associated with increased frequency, urgency, and painful urination. Endometriosis involving the gut can produce GI manifestations such as diarrhea, constipation, bowel cramps, and painful defecation. Thoracic endometriosis can cause chest pain, pneumothorax, hemoptysis, and neck pain. Overall, endometriosis is associated with a decreased quality of life for the affected individual. Endometriosis is difficult to diagnose clinically, and there are no biomarkers available to detect or exclude endometriosis as a cause of pelvic pain. Laparoscopic visualization with histologic verification is the standard for diagnosis. These images are taken from a nice recent review on endometriosis published in the New England Journal by Zondervan and colleagues. The image on the left shows 4 powder burn lesions on the pelvic sidewall. The middle image shows a hyperemic or hemorrhagic endometriotic focus, and the image on the right shows an endometrioma or a chocolate cyst of the left ovary that's been punctured and is extruding dark hemorrhagic contents. The degree of involvement ranges from superficial lesions to deeply infiltrating endometriosis. The most widely used staging criteria comes from the American Society of Reproductive Medicine, and they define stage 1 disease as minimal disease with isolated implants and no significant adhesions. Stage 2 disease is defined as mild disease with superficial implants and no adhesions, whereas stage 3 is moderate disease with multiple implants, including peritubal and or periovarian adhesions. And stage 4 disease is severe disease with dense adhesions. Although this staging system is used to classify the degree of involvement, stage does not correlate with symptoms, treatment response, or prognosis. In general, histologic diagnosis of endometriosis requires two of the following features: endometrial glands, endometrial stroma, and/or evidence of hemorrhage, usually in the form of hemosiderin-laden macrophages, or even overt hemorrhage. The presence of hemorrhage in hemosiderin may be characteristic, but it is also nonspecific, and thus it's preferable to have both glands and stroma to minimize overdiagnosis. Areas may not have well-defined endometrioid-type glands, and especially if cystic may look like the image on the right. Here, identification of the glandular component, stroma, and hemosiderin-laden macrophages allow for a diagnosis. However, sometimes a nondescript or scant epithelial lining is present, requiring a prolonged search for the endometrioid epithelium. If no endometrioid epithelium is identified, the term hemorrhagic cyst of undetermined origin can be used. Hormonal effects and epithelial metaplasias are also seen in endometriosis. Sometimes the classic endometrioid glands and stroma are not identified, and instead other patterns are observed. These can include prominent xanthomatous cells, seen in the left image, decidualized changes, seen in the middle image, which may be confused for either xanthomatous change or a corpus luteum, or even metaplastic epithelial changes, most typically mucinous, as seen on the right. For specimens that are scant in nature or difficult to interpret histologically, immunohistochemistry can be a useful ancillary test to help diagnose endometriosis. Here's a peritoneal biopsy taken from a patient where we used IHC to confirm the diagnosis. The Mullerian epithelium is highlighted by PAX8, and the stroma is highlighted using CD10. Also note that the epithelium appears more visible in the deeper sections as well, illustrating that levels should be considered on peritoneal biopsies if there is a clinical concern. The origin of endometriotic tissue is currently unclear, and there are a number of theories proposed to explain its pathogenesis. The most popular theory is that of retrograde menstruation, defined as the reflux of menstrual debris and viable endometrial cells through the fallopian tube and into the peritoneal cavity, leading to implantation. This theory is supported by the fact that retrograde menstruation is common. It explains the finding of superficial endometriosis in the peritoneal cavity, as well as the development of endometriotic cysts. The second theory, known as the metaplastic theory, proposes that peritoneal mesothelium undergoes a transformation into endometrial glands and stroma, and this theory has been suggested to explain the presence of endometriosis in women with Mullerian duct defects. A third theory is that of benign lymphatic or vascular metastasis, in other words, the transport of endometrial cells through the lymphatics and blood vessels to explain the findings of extrapelvic endometriosis. A fourth theory is the progenitor cell theory, and this suggests that stem cells either from the endometrium itself or circulating from the bone marrow implant and differentiate into endometrial glandular and stromal cells at the sites of endometriosis. Although endometriosis is considered a benign lesion and non-neoplastic, it does share several characteristics with invasive cancer, including the capacity to invade and damage tissue and its ability to implant and spread to distant locations. Women with endometriosis have an increased risk of developing epithelial ovarian cancers, and we'll take some time to explain why we think this risk is present. Why does endometriosis invade and damage tissue? How can these cells survive in an ectopic location and spread to different locations? And why is it associated with an increased risk of developing cancer? In part, the answer lies in the fact that endometriotic cells and tissue elicit an inflammatory response and other factors which promote its survival. The endometriotic tissue is not just morphologically similar to endometrium, it is also functional. And whereas normal endometrium is shed and the body expels old tissue through the cervical canal, this shedding cannot occur in the abdominal cavity. We think it is in fact the stromal cells of endometriosis that play a major role in a localized immune response, and thus are thought to be the real culprit in allowing persistence and survival of the ectopic tissue. The stromal cells secrete chemokines, which recruit inflammatory cells, including macrophages, monocytes, lymphocytes, plasma cells, and eosinophils. And these immune cells are activated and release pro-inflammatory cytokines TNF alpha, IL-1 beta, and IL-6, as well as pro-angiogenic factors, growth factors, and adhesion molecules. The stromal cells also secrete aromatase, which leads to increased estrogen production. And this is important because the increased estrogen and the inflammatory milieu leads to increased survival and persistence of endometriotic tissue in a foreign location, and also facilitates a pro-neoplastic environment. There are quite a few studies that have shown histologically benign endometriotic lesions harbor genetic defects that are at least permissive for malignant transformation. Early studies demonstrate a loss of heterozygosity and somatic mutations in P10 occurring in a substantial portion of endometriotic cysts, as well as endometrioid and clear cell carcinomas. More recently, whole exome sequencing has been used to identify somatic mutations occurring in the vast majority of endometriotic lesions, including canonical driver mutations in the genes KRAS, PIK3CA, and ARID1A. Such mutations were all confined to the epithelial component and not present in the stroma in the study that I'm citing. What is the risk of malignancy associated with endometriosis? In one study of 1,000 cases of endometriosis found in pathologic specimens, carcinomas were found in continuity with endometriosis in 0.9% of cases, but the frequency may be even higher if you consider endometriosis simply found in the same organ. Of note, this study is likely biased toward the upper end, since it was based on confirmed pathologic sampling. In a Danish cohort of 99,000 women, Brinton et al. Showed that women with endometriosis had a predisposition for ovarian cancer that was restricted to endometrioid and clear cell histologies. And this association has been confirmed in a number of other subsequent studies. Malignant transformation of endometriosis is believed to be a stepwise progression through an intermediate precursor lesion. Although yet to be clearly defined, there are several possibilities, including endometriosis that is contiguous with ovarian malignancies and endometriosis that displays histologic features that distinguish it from both benign and malignant entities, in other words, atypical endometriosis, which we'll talk about in a moment. We should consider strict pathologic criteria for establishing whether a malignancy has arisen in endometriosis. And these criteria include cancer and endometriotic tissue should be present in the same organ. A continuous or close histologic relationship should be identified. The cancer must not have arisen from another source. The tumor should be of a subtype that occurs in native endometrium, and a gradual transition from benign to malignant epithelium or atypia in the endometriosis should be identified. Atypical endometriosis is a description of abnormal cytologic or architectural atypia seen in endometriotic foci. Atypical endometriosis was first described in 1979 when Chernobylsky and Morris looked at almost 200 cases of ovarian endometriosis and found severe atypia in 7. None of the patients had carcinomas associated with their endometriosis. They described and illustrated severe epithelial atypia, described as large hyperchromatic or pale nuclei, eosinophilic cytoplasm, papillary tufting, and bridging epithelium. Later, in 1988, Lagranade and Silverberg described 5 cases of ovarian clear cell and endometrioid neoplasms associated with atypical glandular changes in endometriosis. They identified benign endometriosis, atypical endometriosis, and carcinomatous components in all 5 of their cases. The photomicrographs to the right are taken from these 2 publications. Practically speaking, there are generally 2 types of changes that we call atypical endometriosis. There is an endometrioid type, which resembles endometrial intraepithelial neoplasia, and there's also a clear cell type, which exhibits hobnail architecture, eosinophilic cytoplasm, marked cytologic atypia, and has an exfoliative appearance. Let's look at some examples of these 2 different types of atypical endometriosis. Here's a case of isolated atypical endometriosis of the endometrioid type, identified in a fallopian tube that was without associated carcinoma. At high power, you can appreciate a relatively high gland to stroma ratio and a resemblance to EIN, with relatively bland appearing cytology. Here's another case of atypical endometriosis, endometrioid type, that was associated with an endometrioid adenocarcinoma. On the right, you can appreciate back-to-back glands, as well as some cytologic atypia. These photos are taken from our index case, presented as the clinical vignette. On the left, there are more normal but still somewhat crowded foci of endometrioid glands and delicate stroma. But on the right is a focus of what we called atypical endometriosis. We can see that it is also of the endometrioid type. It resembles EIN with crowded back-to-back glands and has a distinct cytology from glands elsewhere in the specimen, signifying a clonal outgrowth. This is a focus of atypia found within an endometrioma, and I would suggest that this is atypical endometriosis of the clear cell type. Note the hobnailing appearance of the glands attached to the epithelium on the left, and at higher power and in a different location, you can appreciate the exfoliative nature of the cells, as well as the marked cytologic and nuclear atypia with prominent nucleoli. There's even a mitotic figure here found in the exfoliating cells. Here's another focus that was called atypical endometriosis within an endometrioma. At low power on the left, you can appreciate epithelium, hemorrhage, and stroma. At higher power on the right, the focus of epithelium with cytologic atypia and nuclear atypia is seen. It has an exfoliative appearance, and it's suggestive of atypical endometriosis of the clear cell type. For the next sections, on endometrioid, clear cell, and seromucinous tumors of the ovary, I will present epidemiology and clinical features alongside classic gross and histologic descriptions. I've also gone through cases our group has diagnosed at Duke and selected several low and high power images of some of the more challenging entities. Next, we will discuss endometrioid tumors of the ovary, and these account for roughly 8% of ovarian epithelial tumors. Endometriomas are cystic forms of endometriosis. Although they are commonly found in the ovary, they may be present elsewhere in the pelvis. They are a common cause of ovarian enlargement in the 4th and 5th decades, and they can present with pain. They are often associated with endometriosis in other locations of the pelvis. Grossly, the cyst can be quite large, and the lining is usually irregular with areas of hemorrhage. The cyst contents are typically brown due to old hemorrhage, which gives the appearance of a chocolate cyst as seen in the upper right photo. Classic endometriotic cysts are lined by endometrial epithelium overlying stroma and associated with hemorrhage as seen in the bottom right photo. Mucinous or ciliated tubal metaplasia may be present. In endometriomas associated with endometrioid and clear cell carcinomas, the normal appearing epithelium has been found to harbor identical mutations in canonical tumor-associated genes, such as ARID1A, P10, and PIK3CA, suggesting that these molecular alterations occur in endometriomas and play a role in tumor development. Unlike serous cystadenomas and serous borderline tumors, endometrioid adenofibromas and borderline tumors of the ovary are uncommon, representing less than 1% of all benign ovarian tumors. Approximately 63% of patients have associated endometriosis. Additionally, coexisting endometrial hyperplasia and/or carcinoma is a common finding. Histologically, endometrioid borderline tumors demonstrate two major growth patterns, adenofibromatous and intracystic growth patterns. Glandular proliferations may be crowded, have back-to-back endometrial glands with mild or moderate cytologic atypia, and may be analogous to EIN in the uterus. Focal cribriforming may even be present. If the cytologic atypia is severe, a diagnosis of intraepithelial carcinoma can be made. Confluent glandular growth that measures over 5 millimeters or unequivocal invasion should be diagnosed as carcinoma. For endometrioid borderline tumors, the prognosis is excellent, with very few cases of well-documented malignant behavior. Next, I'm going to show you some examples. This is an adenofibromatous endometrioid borderline tumor that was diagnosed at our institution. Note that the majority of the tumor is adenofibromatous with foci of endometrioid glandular proliferation. A small focus that you can see that was dotted here in the inset demonstrates somewhat crowded glands with squamous morels. Here's another case. On the left, is a low-power photomicrograph that shows an intracystic endometrioid borderline tumor, and on the right is a high-power image that demonstrates squamous morule metaplasia and back-to-back glands. The presence of squamous metaplasia and morule should not be confused with confluent or glandular growth or with stromal invasion. Here's another ovarian endometrioid borderline tumor. This tumor was extremely complex and multicystic, and you can see the innumerable cystic spaces that are lined by endometrioid epithelium. As seen in the right photomicrograph, there is at most mild cytologic atypia, though. In areas, there may be an elevated mitotic rate, but the tumor lacks cribriform growth, confluent glands, or destructive stromal invasion. At this time, I'd like to briefly address and define the term microinvasion, which is described as clusters of epithelial cells invading the stroma of a borderline tumor measuring less than 5 millimeters in greatest dimension. Microinvasion can appear as haphazardly infiltrating single cells, glands, or nests of cells with cytologic atypia, and there is no requirement regarding the number of such foci seen in a given tumor. In other words, microinvasion can be multifocal. However, finding microinvasion should prompt additional sampling to exclude a carcinoma. Small studies suggest that microinvasion in endometrioid borderline tumors does not adversely affect outcomes. Endometrioid adenocarcinomas of the ovary are malignant epithelial tumors analogous to endometrioid adenocarcinomas of the uterus. They account for 10 to 15% of ovarian carcinomas and are the second most common ovarian malignancy after serous carcinomas. They are commonly seen in the 40s and 50s, and around 40% are associated with endometriosis in the same ovary or elsewhere in the pelvis. These tumors harbor genetic alterations in beta-catenin, PTEN, or PIK3CA, just as those seen in endometrioid adenocarcinomas of the uterus. They are believed to arise from endometriosis. Interestingly, patients whose tumors are associated with endometriosis are usually 5 to 10 years younger on average than those without. Histologically, the majority of tumors will have confluent or cribriform proliferations of round, oval, or tubular glands. Foci of mucinous metaplasia can be seen, and squamous differentiation occurs in 30 to 50% of cases, most often in the form of squamous morules. The presence of squamous differentiation or morules should not prompt a diagnosis of a grade 2 tumor, which may lead to overtreatment of the patient. Occasionally, secretory changes may be present in the endometrioid epithelium, and care should be taken to differentiate secretory change from frank clear cell carcinoma. We've seen cases at our institution where endometrioid tumors with secretory change will stain positive for markers of clear cell differentiation, so careful morphologic assessment is required in these cases. The prognosis of endometrioid adenocarcinomas of the ovary mimics the 4-subtype molecular classification system of endometrial adenocarcinomas performed by the TCGA, which include MMR deficient, POL-E mutated, P53 abnormal, and P53 wild-type tumors with no specific molecular profile. P53 tumors have poor outcomes, whereas POL-E and MMR deficient tumors have the best prognosis. Molecular classification correlates with survival in multivariate analyses, independent of tumor grade and stage. This figure is taken from one of Carlos's papers on the subject, and it nicely demonstrates the difference in survival between these three groups nicely. They've lumped MMR and POL-E mutated proteins together. In general, a grade 1, stage 1 endometrioid tumor, endometrioid adenocarcinoma of the ovary is followed with observation. However, higher grade tumors will often receive chemotherapy, and this means that there is a critical decision point for pathologists, and grading of endometrioid adenocarcinomas of the ovary should be taken with care. Again, these are general guidelines and may change between institutions and for individual patients, but evaluating grade and evaluating stage are important for prognosis. To illustrate that, the 5-year survival for stage 1 endometrioid adenocarcinomas of the ovary is 78%, and that drops to 63% for stage 2, 24% for stage 3, and 6% for stage 4 cancers. In almost 1/5 of cases, synchronous endometrioid carcinomas are observed in both the ovary and the uterus. Typically, both tumors will be well differentiated and resemble each other. The criteria for distinguishing metastatic disease from synchronous primaries depends on clinical pathologic findings. For cases of low-grade uterine carcinomas that are associated with EIN and/or have little myoinvasion, the ovarian tumor can be regarded as an independent primary. This assumption is supported by the fact that the 5-year survival rate for such patients is 70 to 92%. Some studies have found molecular and immunohistochemical differences between ovarian and endometrial primaries as well, but this is an area of research. In cases of bilateral ovarian involvement, multinodular growth, or lymphovascular invasion, an ovarian metastasis should be considered. Next, we will address clear cell tumors of the ovary, and these account for around 3% of all ovarian epithelial tumors. Clear cell adenofibromas are quite rare but benign tumors and may be found in association with other types of adenofibromas. These neoplasms contain widely spaced, simple glands embedded in a fibromatous stroma. Glands are lined by cuboidal cells with clear or eosinophilic cytoplasm. The nuclei in both epithelial and stromal components should be bland, and mitotic figures should be absent. These tumors are often associated with endometriosis. Careful sampling is recommended to exclude a borderline or clear cell carcinoma. Clear cell borderline tumors are essentially clear cell adenofibromas with cytologic or architectural complexity. They are also rare and account for less than 1% of all borderline tumors. Tumors should be sampled thoroughly to exclude a component of clear cell carcinoma, which would appear as malignant cytology and/or invasive glandular growth associated with a stromal reaction. Clear cell borderline tumors present alongside clear cell carcinomas have been found to share molecular abnormalities such as loss of heterozygosity and loss of ARID1A expression, suggesting a clonal relationship with the carcinomas. Here's some cases of clear cell borderline tumors that I took from our archives. On the left, notice the extensive fibromatous component and relatively limited proliferation of glands. At high power on the right, there is moderate cytologic atypia present. These cells have clear cytoplasm and are somewhat hobnailed and very reminiscent of clear cell carcinoma. This is an example of a clear cell borderline tumor that has a more extensive glandular component, but notice that the cytology is much more bland than in the previous case. Whereas the previous cells were hobnailed and had some nuclear atypia, these cells are flat, cuboidal, and have small centrally placed nuclei. Clear cell adenocarcinomas of the ovary are morphologically analogous to those found in the uterus. The mean patient age is 55 years, and these tumors are found to arise in endometriosis in 50 to 70% of cases, more than any other subtype. Grossly, the tumors are most often unilateral and composed of solid to cystic pale yellow nodules, classically found lining an endometriotic cyst. These tumors are composed of clear eosinophilic and hobnail cells with tubulocystic, papillary, and/or solid growth patterns. The cells are clear due to the presence of glycogen. These tumors are high grade by definition and will usually receive chemotherapy regardless of stage, which is the most important prognostic factor. Immunohistochemistry can be essential for distinguishing clear cell carcinomas from their endometrioid or serous counterparts. The stains that we primarily use are HNF1 beta, napsin-A, and AMACR. Note that the morphology here in this photograph is decidedly clear cell. HNF1 beta is diffusely and strongly positive, but this is considered to be the least specific marker, with napsin-A and AMACR considered to be more specific, but the staining can be very focal, as in this example. The final category of ovarian epithelial tumor that we'll discuss are the seromucinous tumors. The seromucinous neoplasms are a relatively new category of ovarian epithelial tumor introduced in 2014 to the revised WHO classification of tumors of the female reproductive organs. Like other ovarian malignancies, they are divided into benign, borderline, and malignant counterparts, with borderline being the most common entity in this subgroup. The term seromucinous was first used in 1976 by Fox and Langley to describe tumors composed of both endocervical type mucinous epithelium and serous type cells. In 1988, Rutgers and Scully published papers that divided these tumors into those with pure endocervical type epithelium called Mullerian mucinous cyst adenoma of borderline malignancy, and another group composed of mixed endocervical type mucinous, serous, and endometrioid cells with abundant eosinophilic cytoplasm, which they called ovarian mixed epithelial papillary cyst adenomas of borderline malignancy. There are no clinically relevant differences between these two categories, and later authors ended up combining them into a single group. And this history is somewhat complex, but also explains the nature of the neoplasm. But a major point here is that seromucinous tumors are characterized by an admixture of various cell types, including endocervical type mucinous, endometrioid, ciliated/serous, and squamous type epithelium. A third of these tumors are associated with endometriosis, hence why they're in this lecture today. And it is this close association with endometriosis, as well as the presence of multiple different cell types, that supports a pathogenesis for these tumors that is distinct from intestinal type mucinous tumors of the ovary. Seromucinous cyst adenomas are benign cystic neoplasms with 2 or more Mullerian cell types that each account for at least 10% of the epithelium. These tumors are uncommon and account for 1% of benign epithelial ovarian neoplasms. Tumors typically present as unilocular cysts that may contain serous or mucinous fluid. Cysts are lined by an admixture of ciliated and endocervical type mucinous cells, and less often endometrioid, transitional, or squamous cells. Here are some images of seromucinous cyst adenomas. On the left, you can notice the cyst wall, and there's a bit of a fibromatous component present too, which is not shown in the higher power image, but is present in the inset. At top, you can see that there is Mullerian epithelium with eosinophilic cytoplasm and some ciliated cells. And here at the bottom, you can see that there is endocervical type mucinous epithelium. This is another case of seromucinous cyst adenoma diagnosed at our institution. And you can see that there's a substantial fibromatous component with multicystic spaces. Here there are detached fragments of mucinous epithelium, as well as Mullerian epithelium with eosinophilic cytoplasm. In the lower right image, here is epithelium present with well-defined cilia, signifying the serous component of this tumor. Previously, seromucinous borderline tumors were considered a subset of mucinous borderline tumors, and they account for 15% of tumors in that mucinous borderline tumor category. Although most patients have stage 1 disease, a minority may have implants or even lymph node involvement. Grossly, the tumors are typically unilocular, contain viscous fluid, and display friable papillary excrescences. Up to 40% can be bilateral. Microscopically, these tumors display papillary growth patterns similar to hierarchical branching seen in serous borderline tumors. The epithelial component is composed of at least 2 types of Mullerian epithelium, with mucinous and ciliated epithelium being the most common. The cells often display a conspicuous cytoplasmic eosinophilia with low-grade nuclei. As with all borderline tumors, microinvasion and intraepithelial carcinoma may be present. Seromucinous borderline tumors are associated with a good prognosis, even in the presence of peritoneal implants. Here's a serous borderline tumor, seromucinous borderline tumor that we diagnosed. Although this tumor was predominantly cystic, there were foci of papillary growth, similar to serous borderline tumors. In the high power image on the left, foci of mucinous metaplasia can be seen in a background of some ciliated cells. In other locations, as seen in the one on the right, there are papillary tufts with this conspicuous eosinophilic cytoplasm that is characteristic of these seromucinous borderline tumors. Here's yet another example of a seromucinous borderline tumor. This tumor had both simple components as well as substantial papillary growth in areas of the cyst. Notice that in this focus on the left, the ciliated and mucinous epithelium merge within a single cystic space. There are papillary areas as well, and these showed complex epithelial tufting and hyalinized stroma, which can be seen in these tumors. This is yet another case of seromucinous borderline tumor. Much of this tumor exhibited papillary growth, as seen in this inset. Extracellular mucin, as well as foci of intracellular mucin, can be seen, along with a bland hyalinized stroma. On the right, this high-power image demonstrates cells with both mucinous and eosinophilic cytoplasm, which is also characteristic of these seromucinous tumors. Seromucinous adenocarcinomas are predominantly composed of serous endocervical type mucinous epithelium as the cystadenomas and borderline tumors as well. They are uncommon and have only been characterized by a few small case series in the literature. Grossly, these tumors can be unilocular or multicystic with solid areas or papillary excrescences lining the cysts. The largest study of seromucinous adenocarcinomas contained 19 cases, and the patient's age ranged from 16 to 79 years with a mean age of 47. 16 cases were unilateral, 3 cases were bilateral, and the sizes ranged from 1.8 to 18 centimeters. 80% of the tumors were stage 1, and 80% of the tumors had characteristic features of admixed cells, including the 80% had endocervical-like mucinous cells. Endometriosis was identified in the same ovary in 10 cases, almost half, and 10 cases demonstrated a component of seromucinous borderline tumor. Patients with stage 1 disease had a favorable prognosis, but higher stages fared worse. I hope you've enjoyed this lecture. In it, we discussed the epidemiology and pathophysiology of endometriosis and its relationship to ovarian and peritoneal neoplasms. We then discussed in detail the 3 major classes of ovarian neoplasms that are most associated with endometriosis, those being the endometrioid, clear cell, and seromucinous subtypes. Thank you for listening, and with that, I'll be happy to take any questions.
Thank you, Dr. Strickland, for this excellent talk on this complex topic of endometriosis and associated ovarian neoplasms. There are some questions that I can see online. The first question is, do you use Emacar for clear cell carcinoma? And how do you interpret this stain? Is it widely used for clear cell carcinoma?
Yes, I believe it is widely used for the diagnosis of clear cell carcinoma. We use it at our institution, and I know of other institutions that use it as well. We typically stain our clear cell carcinomas for it if there's a suggestion that it might be some other type, such as a serous carcinoma or an endometrioid tumor. The thing that's tricky about AMACR is that that only focal staining needs to be seen in order for it to be a positive result. So there's a bit of subjectivity to it, but if your tumor is diffusely and strongly positive with AMACR, it can really help. But keep in mind that morphology and of looking for actual morphology of clear cell carcinomas is the most important aspect of the pathologic evaluation.
Right. The next question is, how to differentiate grade 3 endometrioid carcinoma from dedifferentiated endometrioid?
Now that can be difficult, because I guess for the dedifferentiated type, you'll also see a well-differentiated component, but you'll also see sheets of undifferentiated cells. And I guess it's more of one of degree. Because in your grade 3 tumor, you might expect to see both grade 1, grade 2, and grade 3 components, a nice spectrum, if you will, whereas the contrast in a dedifferentiated tumor should be very stark. But yes, it may be very difficult to differentiate the two. The good thing about it is, though, that these patients are already going to receive chemotherapy, whether or not they're grade 3 or whether they have an undifferentiated carcinoma. So the distinction there really, is one for more of prognosis and pathologic interest.
Right. The next question is, what about seromucinous carcinoma is now considered a variant of endometrioid carcinoma?
So this is a topic of discussion in the literature. There's lots of reasons to think that may be true. The presence of these different subtypes, it's based on morphology alone, and so at least according to the WHO, if you have this admixture of different subtypes, you can classify your tumor as a seromucinous tumor. Now, whether or not seromucinous tumors display the other features of endometrioid carcinomas, like the molecular distinctions, such as I think that remains to be seen because there are so few cases in the literature.
So here's the next question. So this is about napsin. The question is napsin a good marker for clear cell carcinoma, or is it not a good marker for clear cell carcinoma?
Well, we make the best, we do the best with what we have, and I think that's that we rely on it. Typically, we want 2 out of the 3 markers, those 3 markers being HNF1 beta, napsin A, and AMACR. And I can't tell you how many times we've stained clear cell carcinomas to find focal staining of AMACR or focal stain of napsin, only to find the other marker is diffusely and strongly positive. So I think by itself, I would not use napsin, but in conjunction with the other 2 markers, I think that it's very good.
Right. The next question is, how do you differentiate clear cell carcinoma of ovary from cervix?
So meaning like a metastasis from a cervical primary, or I'm not sure.
Seems like that. Yeah, I mean, it is not specified. Probably, or probably that's what it means.
Yeah, I think that you can get cases of cervical carcinomas that metastasize to the uterus. That's going to require, well, first, if you receive a total hysterectomy and bilateral salpingo oophorectomy, that distinction should be pretty clear, because you'll notice a mass in the uterus, or at least a mass in the cervix, or tumor in the cervix on your histologic section. But if you're talking about endocervical type mucinous epithelium versus clear cell carcinoma, that's, again, the clear cell markers are going to help you there, as well as the morphology.
So here's the next question. The question is, if there are 2 synchronous endometrioid tumors, that is large unilateral ovarian mass with intact capsule, inner myometrium, grade 1 to 2, but there is very few LSVI in the uterus, how do you report it and stage it?
So that is your call, how you report it. And this is we struggle with these cases when they come up, right? The main thing to do is to make a comment. And in that comment, you basically tell the clinicians what you're doing. You say, these are the features that we see in the ovary. These are the features that we see in the uterus. They may be synchronous primaries, or they may be metastatic. I'm staging it as a synchronous primary because blah. And, these patients typically have a very good prognosis. So you kind of have to make your case in these situations. And the presence of focal LVI may or may not prompt a clinician to be more aggressive or not, but in the end, it's their call, because it's kind of an uncertain area.
Right. There is a next question. It says that the plasma cell infiltration in clear cell carcinoma, do they have any prognostic significance?
Not that I'm aware of. Not that I'm aware of. We talk about tumor infiltrating lymphocytes. I haven't seen very many discussions about infiltrating plasma cells, but as of right now, I think the consensus is that there's no clear-cut prognostic relevance. Like I'm not gonna start counting lymphocytes or counting plasma cells in your reports, but I think it is interesting when you talk about what that means in the context of the molecular abnormalities of the tumors and whether or not they're going to be susceptible to immune modulating therapies. And I don't know if the answer's out on that yet.
Here is this next question. How can we differentiate atypical endometriosis from endometrial carcinoma in situ? And there is an additional question to that, is that how can we measure the depth of invasive endometriotic carcinoma if associated with atypical endometriosis?
So just to
I can repeat the question.
Right. So let me address that second one. I'm not sure where you're like, if you're talking about measuring the size of the lesion, you know, that's one thing, and I think that it's just a judgment call on your part. But I just don't know if it's really that important to do in that context. And as far as the first question, can you repeat that first part, Rafat?
Yeah. So how to differentiate between atypical endometriosis and endometrial carcinoma in situ?
Right. So endometrial carcinoma in situ is not really a diagnosis that I make. If you're talking about maybe if you're thinking of an intraepithelial carcinoma, that can be difficult. Atypical endometriosis, though, should be associated with stroma. It should be in a somewhat cystic space. You know, like I said in the talk, it does resemble EIN, and so that is kind of an intraepithelial neoplastic sort of process. But yeah, I think that it can be difficult. You know, differentiating atypical endometriosis from just reactive atypia can also be difficult too. You can get reactive atypia seen in Aurea stella effect in endometriosis, and so that can be difficult as well. Again, I think it's a judgment call on your part. If you see overt cytologic atypia that is just beyond what you would expect for any sort of reactive atypia, you might want to consider calling an intraepithelial carcinoma, especially if it's in the context of like a borderline tumor or something. Yeah, I think that can be, I can imagine that might be really difficult, but I would look for stroma and hemorrhage and other signs that this is in fact endometriosis and not just uncontrolled glandular growth. That's how I would answer that question. Good question.
All right. The next question is regarding seromucinous carcinoma. Is there any criteria for histologic grading for seromucinous carcinomas, or they are graded the same as endometrioid carcinomas?
Yes, that's a very good question as well. They would be graded in the same way as an endometrioid carcinoma.
Right. I think that is the last question that I had. Oh, here's one more I can see. So it's about P53. So do you use P53 always for serous carcinomas?
For serous carcinomas, so that's interesting. So I really like P53. If you know how to interpret your P53 staining and you're not over-interpreting your wild type staining, P53 can be very useful, especially in the context of cytologic evaluation. So if a patient presents with carcinomatosis and sampling is performed with, via CT guided FNA or something, I think P53 is extremely helpful in that context. When you have the ovary in front of you, it's a little bit less useful because morphologically you should be able to differentiate a lot of your serous carcinomas, but sometimes you can't. And for those cases where there's even a little bit of a question, yeah, I'll get a P53 for sure. P53 for your I usually don't get those for endometrioid carcinomas or clear cell carcinomas. I was looking in the literature, and there's a little bit of a funny thing about clear cell carcinomas. Clear cell carcinomas of the uterus have positive or abnormal P53 staining in about 30 to 40% of cases, but that number is much less for ovarian clear cell carcinomas, and I don't really know why, but I just think that's just something I found interesting and that I'd throw out there. But yeah, I don't get P53 for all cases, but I definitely I think I do whenever I get this the Mullerian, high-grade Mullerian adenocarcinomas that you see on like CT-guided FNAs and stuff.
Right. And again, one last question. I could see that this is about clear cell tumors. So, the question is, borderline clear cell tumor, does it exist in practice?
Yes. So we have made that diagnosis here. It can be very scary, right? But I think that's the purpose of the borderline category. And I think the clinicians are smart enough to know that these patients really need observation. And I would reserve it for those cases like the ones that I showed you. I think I showed you two cases. One had a very, very robust fibromatous component and a small glandular, clear cell glandular proliferation. And then the other one, there was a lot of glands, but the cytologic atypia just wasn't there. But I'll admit it's kind of a brave diagnosis.
Thank you again, Dr. Strickland, for this excellent lecture and taking time to answer all these questions from our viewers. And you would be really very delighted to know that you had several hundred viewers from so many different corners of the world. And I could at least keep track of viewers from at least 25 different countries. And I would name a few. Our viewers joined from Ethiopia, Sudan, Malaysia, Chile, Philippines, Dominican Republic, Romania, Taiwan, and a special shout out to Belma and Barca, who joined from Bosnia as well. And there were many more. And thanks to all our viewers for joining our lectures. And if you like our lectures, please follow our Facebook page as well as subscribe to the YouTube channel, that is Pathcast. And please subscribe to our newsletter so that you can stay updated with all the upcoming lectures, and visit our website, that is pathologicast.com, so that you can access all the live and recorded lectures. And there are also PDF of some of the lectures, and in fact, Dr. Strickland's lectures PDF will also be available. You can access the website for the PDF. And our next Pathcast lecture is coming up next Tuesday, that is October 27th. And we will have a lecture on liver pathology, which will be delivered by Dr. Bob Anders from Johns Hopkins Hospital. And the topic would be diagnosing hepatocellular carcinoma. Hope to see you then. And thank you again, Dr. Strickland, for joining us today.
Thank you.
Thank you.